In the era of 3D and 4D imaging, everything is possible being diagnosed, even uterine peristalsis. If we imagine the human body for an instant with its muscles, its digestive system or its heart, we would imagine them with movement. However, when we visualize the uterus, we imagine it static, only with the changes caused by menstrual cycle. I hope this idea will change after this presentation. Uterine peristalsis changes to the menstrual cycle, fulfilling their purpose. Firstly, they have high intensity and low frequency to release endometrium during menstrual phase. Then the directionality changes and the peristalsis increases their frequency, which helps the transport of the sperm to the fallopian tube. Finally, frequency of peristalsis suffers a decline due to the progesterone effect, helping the embryo so it is not rejected and assisting it to implant during secretory phase. Uterine peristalsis, as well as progesterone as an inhibitor of uterine contraction, play the role during the implantation of the embryo. Both have shown their opposite effect on the results of the treatments. Uterine peristalsis may add information about the functionality of progesterone. It was in the 90s when studies of uterine contractility began. It was then when video recording accelerating method was established to assess uterine peristalsis. Our study aims to show a modification and update of the method that already exists, implementing 4D ultrasound techniques. 4D adds information because 2D ultrasound is performed simultaneously. Therefore, it makes it possible to assess contractility in both images. Then coronal view improves visualization of the movements and it allows to see right and left sides as well as fundus. Finally, directionality and frequency are better seen because it is possible to identify all contour of endometrial cavity. This 4D image is the first dynamic ultrasound scan that was performed on a patient. From this first 4D scan, we decided to assess uterine peristalsis as follows in patients with recurrent implantation failure. First, a 3D ultrasound is carried out in the lithotomy position. Coronal view in high definition live is obtained to practice how to execute later on using 4D. Then the patient is placed in the supine position without removing the vaginal probe and 4D is achieved. Video is recorded for 6 minutes. When it is finished, the video is processed to speed it up 15 times. In this slide, we show how to perform 3D ultrasound to obtain a coronal view using HD Live. 4D ultrasound caption should be performed with the same settings that 3D ultrasound. It is important to enlarge the window or the region of interest as much as possible, as well as to increase the 4D angle until 120 degrees. The position of the probe should be straight while the patient lies down. During the exploration, sagittal section of the uterus must be taken in 2D to obtain a coronal view in 4D. The greatest difficulty faced during 4D ultrasound is to control patients' movement without losing the uterine coronal view. Uterine peristalsis is like waves that go from the cervix through the endometrial cavity to the fundus, moving and modifying it. They are easily visible if we pay attention to the cervical canal, being able to see the origin of the contraction. Progesterone plays an important role affecting uterine peristalsis. Our interest to explore the correlation between progesterone levels and uterine peristalsis has been led by the importance of showing the potential role on reproductive outcomes and providing credibility to this new tool. Following our protocols, uterine peristalsis has been assessed in 197 patients with recurrent implantation failure between 2018 and 2019. A non-standardized progesterone regime was established. Therefore, it has been used interchangeably, vaginally and subcutaneously. The minimum dose used was 800 mg of micronized progesterone taken vaginally. Soon, the inverse association of uterine contractility and progesterone levels has been noticed. Consequently, the last quartile of uterine contractility, which was in patients with more than 1.51 contractions per minute, had less progesterone by having an average of 15.9 nanograms per milliliter. The inter-observer reproducibility has been also analyzed. To do so, we deliver 50 ultrasounds to a senior doctor, to a junior doctor, and to a nurse. An intra-class correlation coefficient of 0.75 was obtained, which indicates a moderate reproducibility. Although our study is limited to the measurements of uterine peristalsis, it is impressive to observe the dynamic behavior of the uterus. Asynchronous patterns and arbitrary directions deserve further studies to know their implications. Limitations include access to 4D ultrasound machine, experience of the sonographer, patient mobility, and image quality. In conclusion, it is worth to assess uterine contractility since enough evidence exists about its influence during embryo implantation. 4D ultrasound provides benefits because it adds information to the technique that already exists. Moreover, coronal view is identified. Despite it has a moderate reliability, it could be improved by a period of training for the professionals who will assess uterine peristalsis. In addition, the eventual association with progesterone could give information about who can have benefits to treat uterine peristalsis by adding progesterone. However, further studies with good prognosis patients should be carried out to increase the knowledge about uterine peristalsis and look for potential benefits of progesterone as treatment for selected patients. Furthermore, it will be interesting to assess the effect of the doses of progesterone administered and its route of administration on uterine peristalsis. Eventually, progress could be made towards the development of software that allows a complete automation of peristalsis assessment and perhaps the use of models incorporating artificial intelligence that allow a better diagnostic and prognostic approach. Finally, I would like to thank the entire team of Instituto Bernabeu for always supporting me.